So we're very excited to have him on board. Welcome, Dr. Robertson, and we're just so glad to have you with us today.
Well, thank you very much, Dr. Tosi, and hello, everybody. It's certainly a real pleasure to be joining you from the far South Pacific to talk to you about the filaminopathies. I hope you can see my slides, and
we're good.
Oh, that's great. So, thank you for the kind introduction. The filaminopathies have been an engrossing sort of preoccupation of mine throughout my career. They represent a broad group of disorders characterized by mutations in 2 of the 3 filamin genes, at least those phenotypes that affect the skeleton. And what I want to introduce you today is predominantly a clinically oriented introduction into these phenotypes, and to talk a little bit about what we understand about the pathomechanism, but to unashamedly expose really our ongoing and substantial ignorance as to how on earth these cytoskeletal molecules called the filaments influence skeletogenesis. So introducing the filamin gene family first of all. There's 3 paralogs of filamins, A, B, and C, over the human genome. And fundamentally, they're filamentous, hence their name, intracellular actin-binding proteins. And one of these, filamin A, is the genes located on the X chromosome, and the other 2 are autosomal. The filamins were discovered by American groups several decades ago and implicated initially in cell migration and cancer-associated biology. And so much of the literature around their cell biology is still centered upon these functions. They're almost ubiquitously expressed, at least filamin A and filamin B are, and therefore their implication in multiple cellular processes really sort of make understanding what's specifically happening within the skeleton quite challenging. On this micrograph here, you can see a dual staining of normal skin fibroblasts with filamin A in green and filamin B in red. And as you can see, they occupy different cellular compartments, even though they have very similar structure and biochemical functionality. What they fundamentally do at their most reductionist level is bind actin. So filamins form dimers, and you'll see the red filamin molecule on the right of this slide dimerize through their C-terminal domain and form these Y-shaped structures. And what that structure enables is the binding and cross-linking of actin fibrils. So you'll see these blue actin monomers nucleate into dimers, trimers, and then F-actin filaments. And then orthogonal networks of actin are then cross-linked and strengthened by filamins, most typically in the subcortical cell membrane area, but certainly throughout the cell as well. So that's filamin at its most fundamental and stripped down biochemical state. But its biology and biochemical functionality extends way beyond that. So on this slide, I've got a filamin dimer again, the actin binding domains in red at the top at the N terminus and the dimerization domain at the C terminus. And in between those 2 moieties is a strand of 24 what we call filamin repeats. So they're immunoglobulin type repeats of beta barrels. And basically, these immunoglobulin-like repeats have a host of functions which are both biophysical and biochemical. And what I mean by that is that they bind multiple cellular proteins, including some which are very central to bone biology, as well as fold and rearrange themselves to become biophysically responsive to mechanical force. And that's going to be one of the themes of my talk this morning. So our host of allelic filaminopathies, what I like to call is the spectrum of disorders which go under that broad rubric filaminopathies, summarized on this slide. You can see the X-linked filamin A has both a loss of function and a gain of function set of conditions, and a lot of my talk this morning is going to be on the gain of function conditions. Filamin B leads to 2 skeletal dysplasias, which I'm also going to talk about. But filamin C is a neuromuscular deal for the most part, with a loss of function myofibular myopathy and a gain of function neuropathy featuring as part of those forms of filaminopathies. But today we're all about bone, and it's those three squares in this 3x2 matrix of filaminopathies which we're going to focus on today. So to begin with, mutations in filamin A, which is where it all began back in the late 1990s, myself and others working hard using clinical phenotypes and groups of patients recruited from over the world. We found using a positional cloning approach that filamin A mutations underlay a large number of related, phenotypically related, but still distinct disorders that were X-linked in nature. And so I'm not going to talk about the loss of function disorders very well at all today, but they are something that are quite phenotypically distinct from the skeletal disorders that are the focus of today's talk. On this slide, I try to demonstrate that dichotomy, that the loss of function disorders are predominantly neuronal or neuromuscular. They're characterized by a neuronal migration disorder for the most part, but some very distinctly focused mutations lead to a myopathy, which is intestinal in nature as well. So that's the nature of the loss of function conditions, and it's very, very rare that you actually see through a variety of sophisticated molecular mechanisms that you have overlap or combination between these loss of function phenotypes and the skeletal disorders I'm going to spend the rest of my time talking about. So they're distinct. And the evidence for the loss of function being the basis for the loss of function neurological disorders is overwhelming. The nature of the gain of function still remains relatively enigmatic for the skeletal disorders, however. So just focusing on them, for filamin A, we have the complicating fact that actually we have hemizygous individuals that present with their phenotypic expression of these disorders, and then of course heterozygotes, females as well. And so we have complexity in being able to identify and describe these different phenotypes, or at least categorize them accurately. In the most mild form, otopalatodigital syndrome type 1, OPD1, is the mildest form of the condition, completely survivable in males, normal cognitive performance, normal stature, normal growth, but patterning defects and abnormalities of the skeleton that I'll talk about in greater detail shortly. And getting increasingly severe in terms of the expression of these phenotypes in males, we move to frontometaphyseal dysplasia, which has more prominent craniofacial abnormalities, and then life-limiting disorders like otopalatodigital syndrome type 2, as seen in the middle of the left of this slide. We then move into predominantly female-limited phenotypes because hemizygosity for the mutations that lead to these conditions is presumptively embryonic lethal, or only in very rare instances has an expression that's clinically detectable. And then finally, we have an unavowedly female-limited disorder, terminal osseous dysplasia and pigmentary cutaneous defects, for which no male has ever been described with those alleles. So we have a spectrum here with the filamin A disorders, which I think is highly illustrative of what the pathogenesis of these conditions might be, at least in furnishing some clues. Centered at around explaining why we have these two different categories, both loss and gain of function, and then disorders which are phenotypically discrete in the gain of function spectrum, is the genotype-phenotype correlation which underpins that observation. So here I've got another dimer of filamin A in green, and on the left we have more or less a randomly distributed, evenly distributed pattern of loss of function mutations across the cognate exons which encode those protein domains that lead to those disorders. The gain of function conditions, though, in red are much more clustered, though. You'll see that a lot are clustered in the actin binding domain, and affect that. And then we have certain repeats over the filamin rod, which are clearly the targets for mutations which lead to given conditions, whether it be Melnick-Needle syndrome, the terminal osseous dysplasia, or OPD2. Frontometaphyseal dysplasia is really the only exception. It seems to be distributed across all of these clusters and lacks less genotype-phenotype correlation than the other Filaminae-related skeletal phenotypes. So the spectrum that I referred to before is again illustrated on this slide. I'm not going to mention the loss of function conditions, periventricular nodular heterotopia and periventricular nodular heterotopia with Ehlers-Danlos syndrome phenotypes, again, because they don't have a skeletal manifestation. But here we have this increasing phenotypic severity, phenotypic severity from left to right as we go from OPD1 all the way through to digitocutaneous dysplasia or terminal osseous dysplasia. And what I'm going to go through now in my subsequent slides is a description of these phenotypes to illustrate to you how we have a progressive array of both patterning defects and defects of the mineralization and formation of the skeleton as these phenotypes worsen in males. So OPD1, as I said before, is characterized by normal height, normal stature, normal neurocognitive performance, but definite but rather subtle defects in the craniofacial skeleton, the skull, and patterning defects in the acral portions of the limbs, and the feet in particular, but also the hands. So the things to point to are in terms of the clinical phenotypes are summarized in the name, really, described by Bob Gorlin back in the 1960s. Oto meaning deafness, so conductive deafness because of the dysplasia of the ossicles, cleft palate, and these digital abnormalities that you see on this slide. So spatulate thumbs is a marked and obvious abnormality, and the so-called tree frog toes, where we have hyperplasia of the first ray of the feet and a rather elongated and long second and third toe, are characteristic of this condition. Morbidity associated with this disorder is primarily connected with hearing loss and cleft palate. The digital abnormalities do not sort of disable people to any great degree. There is subtle supraorbital hyperostosis, which is reflected more severely in frontometaphyseal dysplasia, which I'll talk about shortly, but it's less subtle, more subtle than in that condition. Almost all mutations are found in the actin binding domain of Filaminae and serve to actually increase the avidity of binding of actin to filament. Hence the idea that this is a gain of function disorder. The next most severe condition is the most generalized, if you like to put it that way. Frontometaphyseal dysplasia is caused by mutations which are not just found in the actin binding domain, but also spread over the rest of the gene or those located to those clusters I've introduced to you previously. You'll see on these clinical images that the supraorbital hyperostosis is more pronounced in this condition than in OPD1. And we have the beginnings of more disabling skeletal features. The contractural process of the hands, almost like a Dupuytren's contracture, is one of the characteristics of this disorder, as is scoliosis, as you'll see on the right-hand side of this slide. Radiographically, what's prominent is sclerosis of the skull base and absent pneumatization of the frontal sinuses, which is a correlate of that supraorbital hyperostosis. Incidentally, some patients actually present for cranioplasty and remodeling, facial frontal remodeling for cosmetic regions, and the results are actually hearteningly good. You'll see on that radiograph of the tibia on the right there, we also have an Erlenmeyer deformity of the long bones of these disorders, so a lack of modeling of the metaphysis and the epimetaphysis of bones in this condition, which is also evident in the small bones of the hands and feet. This is the only X-linked Filaminae related disorder which exhibits locus heterogeneity. So frontometaphyseal dysplasia is also caused by two other genes, mutations in two other genes that are autosomal that I'm going to introduce to you later on. Things to point to with regards to the natural history of the condition is that the supraorbital hyperostosis is a progressive entity. In the top left of this slide, we have a Turkish patient with 2 shots of her in toddlerhood and then in her teenage years, indicating progression of the supraorbital hyperostosis over that time period. This makes the diagnosis of this condition in the neonatal, infant, and toddler period a little bit more difficult than it otherwise would be. You also see evidence for a progressive contractual process of the hands, as I mentioned before, which is, seems to relate to the myotendinous junctions of the musculoskeletal system in these patients. It's also sort of indicated in the bottom that the bottom part of this slide that the radiography of the hands of these individuals also demonstrates with time more pronounced undermodeling of the phalanges and metacarpal bones. It's of note that frontometaphyseal dysplasia does have a gradient across the gene as well. So on this slide, I've got a monomer of the filamin A protein with the actin binding domain on the left, the N terminus, and the C terminus on the right. And what I've shown in those 4 rings across that cartoon are the other clusters, which are the filaminopathies relate to filamin A mutations are clustered within. But you'll see that actually the more N-terminal clusters confer survivorship to males, where the more C-terminal clusters seem to be something that locate just to female manifestations or female survivorship with this condition. What this probably points towards is the fact that most of the interactions with extraneous or extrinsic proteins that filamin A engages in relate to the distal part of the rod domain, the C-terminal part of this protein chain. And so any mutations which disturb that part of the molecule are going to disrupt multiple interactions with other extrinsic proteins, which are probably not survivable in the hemizygous state as opposed to heterozygotes. Onto the next most severe condition now, otopelotodigital syndrome type 2. So recognized by clinicians back in the 1970s as having similarities, although much more severe, with OPD type 1, and hence its name. This is the condition which we used in 2 large kindreds to actually locate filamin A as the gene responsible for this spectrum of disorders. As you'll see, we have a much more pronounced skeletal phenotype now. We have thoracic hyperplasia and the appearance of abnormalities of the ossification of the ribs. So thin strip-like ribs with periosteal irregularities. In the hands, we have a pronounced patterning defect as well. Again, more so in the feet than in the hands, but it's still present in both. And you'll see that the radial, the preaxial ray is much more severely affected. There's no evidence, however, that these bones are fragile in any way. And indeed, the ossification indices seem to be relatively unremarkable in this respect. So this seems to be a patterning defect rather than a mineralization abnormality, which leads to fragility. What really helps the diagnosis is the multiple extra skeletal manifestations of these disorders. So we have significant heart defects, kidney defects. Omphalocele is a very definite association with this disorder as well, in addition to cleft palate, as is a feature of OPD1. This is a picture from a case report of another typically affected child with OPD2. Campomelia is clinically quite evident and has its correlates, as I've shown you in the previous slide, with bent long bones, as well as the patterning defects in the hands and feet. Micronathia, cleft palate, thoracic hyperplasia are all features of this condition. The next most severe disorder sends us into a domain where it's very rare to actually see male phenotypes associated with these mutations. Melnick-Needle syndrome is characterized by a highly focused set of only 4 mutations found in that affect repeat 10 of the filamin A rod. Melnick-Needles was first characterized, therefore, as a female limited phenotype, and there was confusion as to whether it was even X-linked for quite some time. These radiographs are relatively mild manifestations of the phenotype. There's bowing of the long bones, as you'll see, particularly that radial kink you can see on the far right, as well as some vertebral anomalies. What's most classic, though, and this slide sort of summarizes more typical findings, is the more pronounced periosteal irregularities that you see in the long bones and in the chest. So ribs are typically strippy, they're irregular, and have many similarities to the male phenotype I just introduced to you with OPD2. Females with this disorder also have a characteristic craniofacial appearance, and it's typical on the upper left there with exophthalmos, round cheeks, and a small jaw. Dental work, dental abnormalities is also a feature with amelogenesis imperfecta, and renal and cardiac abnormalities can be found too. So clearly here we have a filaminopathy which is manifesting strongly for the first time in heterozygotes, even though if you perform X inactivation on these females in blood, fibroblasts, but never been done in bone tissue, showing extreme skewing of X inactivation. This is one of the rare reports of a male with Melnick needle syndrome, and you might appreciate similarities in this male with OPD2. So we have campomelia, irregularities of the long bones, thoracic hyperplasia with thin, strippy, wavy-like ribs, and clear lethality. What might be argued in this sort of instance is the cognate female phenotype. And this is pictures of the mother of this child, who doesn't really manifest any of the craniofacial manifestations of Melnick needle syndrome, even though her radiology with her skull-base sclerosis and rib irregularities has awarded her this diagnosis. So we probably see a close overlap here between OPD2 and Melnick needle syndrome, indicating that it's probably the same pathomechanism that's worse. It's just the mutations are intensifying it as we go further down the spectrum of severity of this set of filaminopathies. The final filament A related disorder I want to introduce to you is indeed exclusively female limited, and not only female limited, but also defined by a single synonymous pathogenic variant that's found very close to the hinge region in the middle of the filament A rod. So this condition has pronounced extraskeletal manifestations as well as a skeletal dysplasia. So we have abnormalities, as you'll see, in the digits. We have webbing in the mouth, perhaps reminiscent of OFD. Digital fibromas, as you'll see on the right there, and webbing in the axillae of that female in this instance as well. Here's this the skeletal manifestations of this female limited condition. So, as is perhaps predicted from the clinical appearances, we have a pronounced dysplasia in the acral regions of the limbs, with some manifestations in the appendicular and axial skeleton, but they're typically much milder than is seen distally. And so you'll see lithic lesions, quite some significant disturbance of patterning in the formation of these limbs. The skeletal dysplasia does not seem to be progressive, however. This is a fixed sort of phenotypic feature when these children are born, but the digital fibromata that are characteristic of this condition do continue to grow, and if excised will regrow as well. And so we have a puzzling condition here that again has reminiscences with Melnick needle syndrome and OPD2, and is characterized by this single variant near the hinge region of filament A. Excuse me. So given this stretch of spectrum of abnormalities caused by mutations in this X-linked gene, what are some good aids for molecular diagnosis? Well, the first is obviously the clustering of pathogenic variants. If you have a VUS across filament which doesn't really fit with your clinical diagnosis, then I think you've got good reasons to begin skeptical that it is perhaps causative The genotype-phenotype correlations, while acknowledging there's a spectrum and an overlap, also are useful, particularly those that relate to male survivorship. And so on this slide, I just want to reorient you to the reality that at the N-terminal part of the protein, missense variants that lead to actin binding domain abnormalities, and those repeat 10 ones which are associated with Melnick-Needle syndrome in particular, are almost definitional of these conditions. And then finally, I want to discuss X inactivation in females because it can be very useful for actually deciding whether a filament A VUS is in fact perhaps pathogenically significant. Skewing of X inactivation is almost inevitable in OPD2, Melnick-Needle syndrome, and terminal osseous dysplasia patients. With those that have OPD1 phenotypes, it's much less obvious and can be relied upon much less as an attendant aid to convicting a variant of being pathogenic. That gradient of what is clearly cellular selection in female heterozygotes reflects also the degree of male survivorship which can occur with those various diagnoses. As I've mentioned before with the extraskeletal manifestations, filament A can also teach us a lot more than just about bone, and perhaps one of the more remarkable examples is this phenomenon of keloid scarring. So we have keloid scarring of the gentleman on the left with a frontometaphyseal dysplasia mutation, and also on the right. And then we have a remarkable manifestation of almost malignant keloid scarring in a patient who has a form of frontometaphyseal dysplasia which relates to the autosomal loci causing this condition. Other manifestations which are quite specific for frontometaphyseal dysplasia in particular also are urethral stenosis, often diagnosed as posterior urethral valves, but arguably not typical posterior urethral valves, and subglottic stenosis of the trachea is also quite a specific malformation associated with FMD. So what connects the biology that connects these disorders to the skeleton? Well, we've performed some conditional knockouts in filament A of in pre-osteoblasts and osteoblast and osteocyte lineages to ask the question, does actual knockout of filament A functions lead to a bone phenotype? Because for reasons that I can't sort of discuss for reasons of time today, the loss of function disorders that are part of the filament A spectrum occur in females only, and therefore our ability to ask the question about knockout of filament in bone can't be asked. What we actually did show, however, and we managed to get a good knockout using OSX-Cree, is to actually show that we do have osteopenia when we remove filament from the osteoblastic lineage. And that's reflected in a reduction in cortical bone volume as well as cortical cross-sectional thickness. And so if we apply the logic here that if this is the loss of function, then the gain of function can perhaps relate to why we have the observation of increased bone formation in these disorders. One of the mechanisms which could be leading to the so-called gain of function is the mechanosensory properties that filaments are considered to have. So by being able to sort of engage and disengage with actin fibrils through the actin binding domain, filaments considered to be a molecule which can dynamically interact with the cytoskeleton as it moves and flexes with physical force. There's also a flexible hinge region halfway down the filament fibril, which also is considered to be flexible and perhaps has mechanosensory properties as well. And then finally, the ROD2 domain in particular has the ability to sort of crush, enfold, and refold and sense mechanosensory force and expose binding sites for other protein partners as well. So that in terms of its capabilities, filament perhaps certainly has the ability to be a mechanosensor. A bit like that in a very physical way by flexing at hinge wunge, or by having this unfurling type process where in the distal part of the C terminus of the filament rod, we have these tertiary structures of filament rods, rod domains, which fold and interact with one another and then unfurl under physical pressure. And parts of the filament, parts of this unfolding filament rod domain can therefore expose accessory sites with integrins and with talin as other mechanosensory components of the mechanosensing apparatus of cells within the skeleton. Downstream from filament A, frontometaphyseal dysplasia has another couple of loci which we've implicated in causation of the disorder. So only about 50% of individuals with FMD have a mutation in filament A. But in this cartoon here in the middle of the slide, I've shown two other players. TAC1, or transforming growth factor beta kinase complex, and its interacting protein TAB2 can also have mutations in it that lead to frontometaphyseal dysplasia phenotypes, which are almost indistinguishable from the filament A related phenotypes. In particular, I want to point you towards not just the filament A and N-terminal mutations in TAC1, but also these individuals here who have a hyper-intense mutational focus with very large numbers of them having just a single missense mutation in in TAC2 that isn't in the domain, that is in the domain that locates and binds to TAB2 itself. So we have again, I think a signature of a gain of function mechanism in whatever signaling pathway connects filament A with these transforming growth factor beta related signaling pathways. The current thinking, therefore, is that we have a mechanosensory input at the top of this slide that locates some kind of signaling connection through the TRAF proteins, probably, to the signaling complex characterized by TAC1 and TAB2, and thereon down to MAP kinase targets that influence osteoblastic function and osteoclastic function as well. So they're my filament A related disorders. I now want to briefly talk about filament B. So this loss of function mutation in filament B in homozygous form, so this is a recessive disorder, leads to this quite remarkable spondylocarpotarsal syndrome phenotype. So we have bridging and fusion of vertebral elements in these children. That's progressive. It's frequently not radiologically visible at birth, but is progressive as these children grow in the first 10 years of their life, so that they have fusions and therefore very significant scoliosis that emerges with time. Diagnostic clues also extend to fusion of the carpal and tarsal bones, which is of no functional significance for these children. Outcome is generally sort of poor in terms of statural growth, but aggressive surgery can actually rescue the scoliotic curves quite effectively. We've also gone on to show that this disorder is genetically heterogeneous as well, and that remarkably an autosomal recessive condition, again in mutations in a gene which encodes an atypical intracellular myosin, leads to a very, very similar phenotype. And you'll see in the radiographs here, again, progressive scoliotic curves appearing because of vertebral fusion. But also subtly, we have myotendinous contractures in some of these children, which is one of the subtle differentiators of the filament B form from this MYH3 phenotype. Interestingly, this recessive disorder is one of those conditions which probably we still have to have some preserved function at the locus to actually have a survivable phenotype. So it seems to be an obligate necessity to have one mutation which is hypermorphic, leading to this condition, and then a second mutation which is typically null. The more familiar gain of function filament B disorders will be now presented, and I think you'll recognize some of these. Perhaps the most famous is Larsen syndrome, characterized by congenital joint dislocations and some acral abnormalities which are strongly reminiscent of OPD1 You'll see down the bottom there the spatulate thumbs and toes, which are similar. The face in Larsen syndrome, we have a flat mid-face, cleft palate, and sometimes a small jaw. But the most, and here are some of the joint dislocations which are legion for this disorder. Knees, hips, and elbows being the most commonly affected. But the most catastrophic part of this condition is the cervical kyphosis, which can occur due to either dysraphism or dysplasia of the cervical spine. About 10% of children with the Larsen syndrome mutation can have this and go on to develop spastic quadriplegia if it's not remediated surgically ahead of time. Other diagnostic aids are accessory carpal and tarsal bones, as shown in the bottom panel. The duplicated or so-called duplicated calcaneum, it's not actually duplicated, it's just an accessory ossification center, is perhaps overrated as a clinical sign and not as commonly demonstrated in patients as the literature might suggest. Mutations again in the filamin B, filaminopathies, it's a very similar story to what we see in filamin A. Mutations in the actin binding domain leading to Larsen and its more severe attendants, which I'll introduce to you shortly, Osteogenesis type 1 and type 3. And then near the middle of the gene, near the hinge, we have more mutations leading to Larsen syndrome and occasionally those severe disorders as well. Loss of function mutations leading to spondylocarpotarsal syndrome can be distributed right throughout the gene. These are the more severe disorders which are associated with gain of function in filamin B. Osteogenesis, literally Greek meaning incomplete and disordered ossification, describes the phenotype very well. So missing ossification of vertebral elements in the neonatal period, very disordered ossification of the long bones of the limbs, and often missing elements in the acral regions, in the hands and the feet. The milder condition, Osteogenesis type 3, is characterized by this drumstick humerus typically, and probably represents just a bridging disorder, a bridging phenotype between Larsen syndrome with its characteristic joint dislocations and the Osteogenesis phenotype, which more profoundly affect long bone ossification in the limbs. So that's my summary Cook's tour of a large number of conditions characterized by mutations in filamin genes which lead to skeletal phenotypes. I hope I've sort of given you some appreciation that there are a large number of phenotypes, but they can be considered to be a spectrum that are joined by a pathogenic process which is still yet to be fully elucidated. Clustered mutations, however, point to the gain of function mechanism and certainly help in molecular diagnosis. And exon activation studies can also certainly assist in this respect as well. So I'd be very interested to hear your thoughts, any experiences you've had in the filaminopathies, and take any questions.